Assalamu alaikum. I hope so. You all guys are fine and doing great. So today, as you guys know, that I have Dr. Samar Alhashimy. She is the endodontist in United States, and she has done BDS, CDS, and MSD. So today she will be discussing about the topic of diagnosis and clinical pulpal classification. Assalamu alaikum, ma'am. How are you?
Assalamu alaikum. I'm good. Thank you for inviting me to give you a lecture here in your channel. And
Well,
today I'm going to talk about the diagnosis and clinical pulpal classification, which is very important topic that everyone should have an idea about the diagnosis and the pulpal classification before doing any root canal therapy.
okay, ma'am. Thank you, ma'am. Ma'am, now you can proceed with your
Okay.
lecture.
So the purpose of diagnosis is to determine what problem the patient is having and why the patient is having that problem. And this will directly relate to what treatment, if any, will be necessary. So the purpose of this diagnosis to relocate us or to relate to what treatment we're gonna do and what treatment is necessary for the patient. Chief complaint, the patient's reason for consulting, which clinicians serve as initial important clues that will help to formulate a correct diagnosis. It should be documented using the patient's own word. This is very important. We should document the chief complaint in the patient's own word. We're gonna like kind of interview the patients. We're gonna ask him about his medical history. So the clinician is responsible for taking a proper medical history from every patient who present for treatment. At every appointment, any change in medical history should be questioned and documented. Vitals should be taken at each treatment visit. Thorough review of medical history will ensure all treatment modifications are made and may provide more information to aid in diagnosis. And then dental history. So we're gonna ask the patient about his dental history, about any experience he has before. So the chronology of event that led up to the chief complaint. It is first filled out on dental history form by patient to allow clinician to figure out approach to asking questions. The history should include any past and present symptoms, any procedures or trauma that might have evoked the chief complaint. SOAP format can be used, which is the subjective, objective, assessment, and plan. The dental history is divided into 5 basic directions of questioning: localization, commencement, intensity, provocation, and duration. Localization, we can ask the patient, can you point to the offending tooth? Commencement, when did the symptoms first occur? So maybe the patient will remember the first symptom he had. Intensity, how intense is the pain? Provocation and attenuation, what produces or reduces the symptom? Duration, do the symptoms subside shortly or do they linger after they are provoked? Examination. Extraoral examination is very important, so we should start with the extraoral examination. We're gonna check if there is any facial swelling, visual and palpation exam of face and neck to determine whether swelling is localized or diffuse, firm or fluctuant. Palpation of cervical and submandibular lymph nodes. Extraoral sinus tracts may open through skin of face, may see scar more visibly. So we have to check very carefully the face. Now, intraoral examination. Routine evaluation of the intraoral soft tissue. The gingiva and mucosa should be dried with either air syringe or 2x2 gauze pad. The tongue and cheek should be retracted, and all of the soft tissue should be examined for abnormalities in color or texture, any lesion ulcerations. Intraoral swellings should be visualized and palpated to determine whether they are diffuse or localized, firm or fluctuant. Sinus tract. Intraoral sinus tract. a chronic endo infection that drains through an intraoral communication to a gingival surface opening or stoma. So we need, or the body needs to draining of the infectious exudate, and that will aid in relief of the pain. Once the causative factors related to the formation of the sinus tract are removed, the sinus tract will close within several days. Palpation. Palpation is done to detect any soft tissue swelling or bony expansion and how it compares to adjacent and contralateral tissues. So we're gonna like kind of press on the periapical area to see if there is any swelling, any bony expansion. In cases of cysts, sometimes the cyst causes bony expansion. So we're gonna try to find if there is any abnormality in this area. So tested by applying firm digital pressure to the mucosa covering the roots and apices. A positive response to palpation may indicate an active periradicular inflammatory process. Now, the other test is percussion. Pain to percussion is indication of inflammation in the periodontal ligaments. So it means that the patient has symptomatic apical periodontitis. So now when we are tapping on the teeth, we are not testing the pulp vitality. We are testing if there is any periradicular inflammation. So when he has symptoms, that means either it's from the pulp or from the periodontal origin. So it's endo or perio. But with this test and with the palpation, we are not testing the pulp vitality. Once the disease state extends into the PDL, the pain may become more localized for the patient. Also test contralateral teeth and adjacent teeth, performed by tapping on incisal for the anterior tooth or occlusal surfaces of posterior teeth, then buccal or lingual, as we could see here in the picture. Now we have to check mobility. Mobility is indication of compromised periodontal attachment apparatus, not indication of pulp vitality. Movement or the extension of infection into PDL. Test by using the back ends of two mirror handles, one on the buccal aspect and one on the lingual aspect of the tooth. Also test mobility in the vertical direction. Any mobility exceed +1 should be considered abnormal. And also we should compare it with the adjacent tooth and contralateral teeth. Periodontal exam, periopropping, indication of depth of gingival sulcus. So it's when we put the perioprop, it will measure the distance between the height of the free gingival margin and the height of the attachment apparatus below. In case if there is a vertical root fracture, so it will cause like localized neuro and very deep perio pocket. So we should be careful in such cases. Furcation bone loss can be secondary to periodontal or pulpal, which is the endo diseases. And in this box, we could see the classes of furcation defect. We have a class 1, class 2, and a class 3. Pulp test consists of thermal or electrical stimulation of the tooth in order to obtain subjective response from the patient. So we talked about the test for the periodontal ligament. Now we are talking about how we can test the vitality of the pulp. So normal response, nothing will, there is no response from the patients. So sensation may be felt during the exam, but it will immediately removed after the thermal stimulus. Abnormal responses, either lack of response, the patient doesn't respond to anything, or lingering pain, or intensification of painful sensation after the stimulus is removed. An immediate painful sensation as soon as the stimulus is placed on the tooth. So first test for the vitality of the pulp is the cold test, our primary pulp testing method. So we have the frozen carbon dioxide, but these days we are using the endo ice. It's easy to use and it's available, and also it's useful for teeth with full coverage crown, especially where our other electric pulp testing is not possible. So we know that we couldn't use the electric pulp test when there is a crown. So our method here to use the cold test. We could see in the pictures on the top left, we could see the CO2, and we could also use the cotton pellet with the endo ice. I prefer the cotton pellet because it will apply the cold to a large area of the pulp. To be most reliable, cold testing should be used in conjugation with an electric pulp testing. Now the heat test. Heat testing is most useful when patient chief complaint is intense dental pain on contact with any hot liquid or food. When a patient is unable to identify which tooth is sensitive, a heat test is appropriate. We can use like a syringe filled with hot water. We can use like isolation of the teeth, and then for that tooth that is isolated, we could use the hot water. Other method, we could use heated gutta percha, compound stick, dry rubber polishing wheel, and heated instruments. Electric pulp testing. Another way to assess pulp neural responses, which is the vitality. When there is no response to EPT, that means the pulp is necrotic. Only works on natural tooth structure. We couldn't use it on the crown. Teeth must be dried and use toothpaste as a medium. Patient must place finger or hand on tester probe to complete the electric circuit. The patient is instructed to remove his or her fingers from the probe when tingling or warming sensation is felt in the tooth. So we're gonna put the rod on the teeth. We should use the toothpaste, and we're gonna ask the patient to hold the tester probe to complete the electric circuit. We're gonna ask him, if you feel anything, any sensation, please remove your fingers. And then we're gonna see the reading. If it's like reach to the top reading, which is the 80, that means the pulp is necrotic. Anything below 70, that means the pulp is still vital. Now the bite test. Bite test indicating when patient present with pain while biting. Pain to biting is seen if pulpal pathosis has extended into PDL, so that means it's symptomatic apical periodontitis, or if there is any crack in the tooth. So we can use cotton tip applicators, toothpicks, orange wood sticks, rubber polishing wheels, tooth sleuth. So that one in the picture is the tooth sleuth. We are applying on the occlusal surface of the teeth, and we're gonna ask the patient to close, and if he feel any pain. And also we're gonna ask him to release now, and we're gonna ask him again if there is any pain during the releasing. So biting pressure should be applied slowly until full closure is achieved. This test also will not test the pulp vitality. It's if the pulp pathosis extend in the periodontal ligaments. Now test cavity. This is invasive irreversible test. So sometimes we couldn't see, or we couldn't like conclude which tooth causing the problem. But this tooth has like a very big restoration. So we might say, I think this is the tooth. So we're gonna do like a test before that. It's not routinely used. It's kind of aggressive. So we're gonna do like a small cavity preparation without anesthesia. And then we're gonna ask the patient, if you feel any pain, just let me know. If he doesn't feel anything, that means the pulp is necrotic. So this is good indication that the pulp is necrotic, and we can continue the root canal therapy on that tooth. Now, diagnostic terminology. So clinical classification according to the AAE 2012. Pulpal, normal pulp, pulpitis, reversible pulpitis, irreversible pulpitis, which we have symptomatic irreversible pulpitis, asymptomatic irreversible pulpitis. We also have previously treated and previously initiated. So normal pulp, there is no pain, no symptoms, so no treatment indication. Sometimes Many patients had trauma and they came. We test the vitality of the pulp. So if the pulp tests vital, nothing, no response, that doesn't need any treatment. It's normal pulp. What is pulpitis? Pulpitis, clinical and histological term denoting inflammation of dental pulp. So clinically reversible or irreversible. So what is reversible pulpitis? The pulp within the tooth is irritated. Stimulation is uncomfortable to the patient but reverses quickly after irritation. So when we put the cold test, he's gonna feel the pain, but it's quickly like removed after the irritation. So usually caused by caries, exposed dentin, recent dental treatment, and defective restoration. So sometimes the patient needs or the tooth needs just replace the restoration and the pain will go away. So this is reversible pulpitis. So what is irreversible pulpitis? From its name, it indicates that it's unable to heal. So it's a clinical diagnosis based on subjective and objective finding indicating that the vital inflamed pulp is incapable of healing. So these teeth exhibit intermittent or spontaneous pain, heightened and prolonged episode of pain that lingers to thermal testing, often 30 seconds or longer. So now the pain is much longer than the reversible pulpitis. Pain is sharp or dull, localized, diffuse, or referred. What's the possible causes of that? Deep restorations, caries, pulp exposure, trauma, or sometimes from the orthodontic treatments. So in this case, this tooth needs treatment, which is root canal therapy. Asymptomatic irreversible pulpitis, it's a clinical diagnosis based on subjective and objective finding indicating that the vital inflamed pulp is incapable of healing. But in this case, there is no symptoms. Possible causes, it's caries, excavation, trauma. So in this case, we're going to depend on the X-ray. We're going to see that the restoration or the caries, it's extend to the pulp chamber. But when we apply the cold or he doesn't have pain, it's different from symptomatic irreversible pulpitis. Pulp necrosis. This is the clinical diagnostic category indicating death of the dental pulp necessitating root canal treatment. Pulp is non-responsive to pulp testing as asymptomatic. Testing other teeth is important because sometimes all of the teeth will not respond to thermal testing. This has happened to many patients that all of his teeth doesn't respond. That not mean all of his teeth require root canal therapy. Possible causes, it's calcification, recent history of trauma, or simply the tooth is just not responding. So now what's previously treated? It's a clinical diagnostic category indicating that the tooth has been endodontically treated and the canals are obturated with various filling material other than intracanal medicaments. So when we are document our diagnosis, so pulpal diagnosis, it's previously treated. But for the periodontal, we're gonna apply bite test, percussion, palpation, we're gonna check the mobility, and then it depends if we have symptoms or we don't have symptoms, and then we're gonna place the periapical diagnosis. But for the pulpal, it's previously treated. And what's about the previously initiated therapy? This is a clinical diagnostic category indicating that the tooth has been previously treated by partial endotherapy, like pulpotomy or pulpectomy. So some cases we need to do pulpotomy or pulpectomy, like emergency procedure. So he has a very painful tooth, we call a hot tooth, and he came like a Friday or Thursday night, and it's like the last 20 minutes. So we should do something. So it depends on the vitality of the tooth. If it's vital, we could do pulpotomy. So we're gonna remove partial of the pulp. If it's necrotic, so we could do pulpectomy. So we have to remove the pulp and we have to do like instrumentation in the canals. kind of instrumentation. And then we're going to put a medication, and then we're going to see him next time. So sometimes we do pulpotomy with vital pulp therapy. We don't need to do full root canal therapy and vital pulp therapy. It's just we're going to do pulpotomy, partial pulpotomy. Sometimes in traumatic tooth injuries, epixification, epixogenesis. So all of these, we call it previously initiated therapy. So when we put the diagnosis, pulpal diagnosis, it's previously initiated. We couldn't, like if we are doing our test, it will not give us like a correct response of the tooth because it's previously initiated. The pulp is gone. So we have to put previously initiated therapy. Now, apical, periapical disease. So we finish with the pulp, now with the periapical area. So we have normal apical tissues. We have periodontitis, which is symptomatic apical periodontitis and asymptomatic apical periodontitis. So the difference between the two, symptomatic, there is symptoms, asymptomatic, there is no symptoms, but in the X-ray, we could see radiolucency surrounding the roots. And also we have acute apical abscess and chronic apical abscess. Normal apical tissue, there is no symptoms. The patient not sensitive to percussion, palpation. Radiographically, the lamina dura is intact and PDL space is uniform and there is no problem. So this is normal apical tissue. Now, symptomatic apical periodontitis, from its name that defines there is inflammation and there is symptoms also. There is response to biting, percussion, or palpation. This tooth may or may not respond to pulp vitality test. So maybe the pulp is vital, maybe not vital. Radiographically, we'll usually see widened PDL and may or may not see an apical radiolucency. So in such case, we could see like widened PDL. Maybe there is an apical radiolucency or not. So what's asymptomatic? From its name, defined, there is inflammation, but there is no symptoms. Radiographically, the tooth will have apical radiolucency. So that's why we know there is inflammation, but there is no symptoms. Patient doesn't have any clinical symptoms. Acute apical abscess. This condition is defined as an inflammatory reaction to pulpal infection and necrosis. So there is pulpal necrosis and it's extend to the periodontal area. There is very acute, painful to biting pressure, percussion, and palpation. Will not respond to pulp vitality test because the pulp is necrotic. Radiographically, may see anything from widened PDL to apical radiolucency, intraoral swelling, and swelling of facial tissues adjacent to the teeth. Patients can have fever and lymphadenopathy. This case, we should treat it immediately. So we could like drain the swelling if it's fluctuant, and also we could open the tooth to do the pulpectomy. So we have to do something. And also we have chronic apical abscess. This condition is defined as inflammatory reaction to pulpal infection and necrosis characterized by gradual onset, little or no discomfort, and the intermittent discharge of pus through an associated sinus tract. So the pulp is necrotic. Pulp necrosis we have. And also we call it chronic. Chronic because it's gradual onset. It's not like a swelling, right away swelling. No, it's gradual onset, and also there is discharge from the sinus tract. We call this case is chronic apical abscess. So thank you so much for inviting me to give you this lecture, and follow me on my Instagram page at IndoQueen5. Give me any comments, feedback, or if you want more topics, just let me know. And to see also endo cases in my page. Thank you so much.
Thank you, ma'am, for the lecture. It was very nice having you, and you gave a very great lecture. It was very helpful. Thanks a lot, ma'am, again for your precious time.
Thank you.
Hope to see you again, inshallah.
Inshallah.
Khuda Hafiz.
Bye.
Khuda Hafiz. Bye bye.